right, we are going to go ahead and start. My name is Chad Severs. I'm the project coordinator for Arkansas Building Effective Services for Trauma. I'm going to let our speaker introduce his topic here and himself a little bit more. I'm just going to go over a couple housekeeping items. And so if you would like to ask a question during the presentation, please use your chat feature, which is found on the right side of your screen. Right now, everyone on the webinar is on mute, so just to kind of help with background noise and that sort of thing. And this is just a reminder that the webinar is recorded, and we'll provide a link to this presentation from our website. So with that, I'm going to turn it over to Dr. Josh Sizzler and let him introduce himself.
Thanks, Chad. Hello, everyone. My name is Josh Sizzler. I'm an assistant professor here at the Psychiatric Research Institute at UAMS. I'm a clinical psychologist, and what I do here is I do about half-time therapy, mostly with adults with PTSD, but somewhat with adolescents also. And I also do research with trauma-exposed populations, both adolescents and adults. So today, I'm going to be talking about exposure-based interventions for anxiety. And exposure is kind of a general procedure for cue-specific anxiety. So what I mean by that is when there's some specific trigger for the anxiety that's not as generalized. So I'm going to be talking about exposure more from the perspective as a general procedure for cue-specific anxiety, but I'll also give kind of a case example of how this could be applied in a specific example where the child has been exposed to trauma and how you could do exposure with trauma-specific cues. So just as a basic overview, we'll talk about what is exposure, what do we mean when we say that word, what's the evidence for using some type of exposure-based intervention, how do we understand why using exposure is helpful, and how can it be implemented in clinical practice. Okay, so what do we mean by exposure? And exposure is kind of a scary term for those who are not as familiar with it. Essentially what exposure-based therapy is it's some type of prolonged and or repeated confrontation with the feared stimulus. So as an example, if a child has a phobia of dogs, exposure therapy for that child would incorporate some type of confrontation with dog-related cues. So it might be seeing pictures of a dog, it might be having a dog in a room, it might be asked to pet the dog. So again, the idea is that the child would have some type of repeated confrontation with the feared stimulus. In this case, the feared stimulus is related to a dog. And there's lots of different ways that you can do exposure, lots of different ways that you can help the patient confront the feared stimulus. So there's graded versus flooding exposure, and I'll talk more about that later, but essentially graded means that you do the exposure in steps. So you might start with a small step, like in this case with the dog phobia, you might start with the child just seeing pictures of the dog, and then you'd move up to more challenging steps, such as having the dog in the room, touching the dog, etc. So that's graded, so taking the exposure in kind of bite-sized steps. And then there's flooding, also called masked exposure, where you try to create a very intense exposure experience where the individual confronts the most feared step for a prolonged period of time. And I'll give some examples of that. And then there's also imaginal versus in vivo exposure. Imaginal just means that the child or the adult that you're doing exposure with, you would have them close their eyes and you would read different scenarios of, of exposure situations versus in vivo, where you would have the child or the adult actually confront those situations in person. But regardless of the modality, all of these different ways of implementing exposure involve some type of confrontation with the stimulus. and the concept really is that simple. The concept of exposure is just that you help the individual confront what it is that is scary to them. But our understanding of why it works and our understanding of how to implement it correctly is a bit more tricky. Excuse me. Okay, and before we go on, something else that's important to mention is that you would do exposure, like when I said before, is when the anxiety is cue specific. So if a child kind of has generalized anxiety and they're non-specific worries, and it's kind of worries about small day-to-day things, exposure is less indicated in those instances. But when the child has a very specific cue, that is when you would want to use exposure. So if the child is afraid of dogs, or if it's a trauma-exposed child and say the abuse happened in a bathroom, or if it was in a car, and it's cue-specific, that is when you'd want to use exposure. And another caveat is you would use exposure when the situation is feared, it's believed to be dangerous, but it's not actually dangerous. So you don't want to put a child in an actually dangerous situation. What you're doing with the exposure is that you're confronting a situation that the child believes is dangerous and or intolerable, so that they can learn they can't tolerate it. So the key thing there is they're confronting the catastrophic interpretation of the situation. You're not actually putting them in really dangerous situations. Okay, so what's the evidence? So again, I'm talking about exposure, generally speaking, as something you would do with cue-specific anxiety or focal fears. In the classic example of a focal fear is a phobia, and exposure therapy overwhelmingly, hands down, is the best therapy for phobias. So I got some quotes up there from David Barlow, who is kind of a nationally renowned researcher in anxiety, and developed lots of treatments for anxiety. And some quotes there. So consensus has developed that the treatment of choice for phobias is exposure-based procedures, particularly in vivo. Another quote, almost all experts agree that exposure to feared objects and situations is both necessary and sufficient for treating the vast majority of patients with specific phobia. So experts agree that if you have a focal fear, such as a phobia, that exposure overwhelmingly has excellent evidence, and that is the treatment of choice. It's better than nothing. So if you compare, say, children who get some type of exposure-based therapy for phobias versus waitlist, it does better. It also does better to more sophisticated control groups. So if you control for just getting attention, or if you control for some other type of intervention, such as cognitive restructuring, or just cognitive therapy, exposure tends to do better for focal fears. So there's great evidence for phobias with focal fears, specifically for phobias. And if we look at other classes of anxiety disorders, exposure therapy also has excellent evidence across pretty much all anxiety disorders. So if you compare, say, an exposure-only intervention for anxiety to, say, a cognitive restructuring type of intervention for anxiety, there's not clear evidence across the board for any anxiety disorder that exposure therapy is necessarily better than cognitive restructuring. There's somewhat there's controversy in regards to which works better, exposure therapy alone or cognitive restructuring. But no one would argue that exposure therapy alone works. And the question is whether or not adding some type of cognitive procedure is necessary. But exposure alone for any anxiety disorder has excellent evidence to establish efficacy. Okay, and as I mentioned before, there's lots of different ways to implement exposure. So if we look at the efficacy or how well exposure works across some of the different ways of doing it, we know that therapist-directed exposure is better than self-directed exposure. So what that means is if you, as the therapist, are doing the exposure with the individual, with the child or with the adult, that tends to work better than if you just give the exposure exercises as homework and have them do it on their own. And that's probably fairly intuitive, as you all know that with anxiety, the hallmark characteristic is avoidance. So if you're with the child's probably going to want to avoid. Oftentimes parents aren't as good with being consistent with following through with some of the self-directed exposure. So it tends to work better if you do it with the child or the adult yourself so that you can make sure it's being implemented correctly. A direct exposure is better than vicarious exposure. So what that means is if you have the child or the adult go through the experience themselves, so confront the situation themselves, it works better than just watching someone else do it. First step in a fear hierarchy might be trying the exposure exercise yourself. So, for example, if it was a dog phobia, you might pet the dog. So vicarious exposure, the child gets to see that you are okay petting the dog. But basically evidence suggests that you shouldn't stop there, that the next step should include the child or the adult confronting the situation themselves. Direct exposure tends to work better than the vicarious. And massed exposure, so flooding, also tends to work better than several smaller sessions. So if you have maybe a prolonged, intense exposure, so in one day, in one afternoon, the child gets to see pictures of the dog, and then gets to see maybe a dog across the room, and then maybe gets to see the dog right next to them, and then maybe gets to pet the dog, maybe have the dog lick its hand, all within maybe a 2 to 3 hour period, so very amassed exposure. So doing it all in one setting, that actually tends to work better than if you stretch it out over smaller sessions. And with that said, any type of exposure, as long as it's implemented correctly, is better than nothing. But getting more specific, that if it's therapist-directed, tends to be better. If you have the child or the adult confront the situation themselves, it tends to work better. And if the exposure sessions are longer and you can complete more steps at once, that tends to be better also. And that last point, with that said, is you have to use some clinical judgment about how much you can do. It certainly is possible to push people too hard and create a situation where they don't feel successful. You definitely want to be careful about that, and I'll talk a little bit more about that later. Okay, so with the evidence for it clearly established, what's necessary and very helpful for conducting exposure therapy is to have a good understanding of why it works. So, and I don't think that this will be a purely academic exercise, and I'm not talking about this just because I think this is interesting, although I do think this is interesting. I think it's important to have an understanding of the history of why that we have thought exposure therapy works. The guy who actually developed this was Joseph Wolpe, and he's actually the developer of systematic desensitization, which you're probably familiar with. And his initial understanding of why exposure therapy helps in reducing anxiety is what he called reciprocal inhibition. And what that means is that the anxious state gets paired with some type of incompatible response. So the way that he developed systematic desensitization was that you teach the individual to become relaxed, so progressive muscle relaxation. And if you pair that relaxed state with the feared stimulus, then the relaxed state inhibits the anxious state. You can't be both anxious and relaxed at the same time. So if you can be around the anxiety-provoking stimulus and put yourself in a relaxed state, over time, that relaxed state inhibits the activation of the anxious state. So in systematic desensitization, how he developed this was he created a fear hierarchy. So again, going back to the example of the child with dog phobia, progression of increasingly more intense situations, seeing a picture of a dog, seeing the dog across the room, the dog close up, seeing dogs at a dog park, petting a dog. You create that hierarchy first. Then you teach progressive muscle relaxations. You teach the child how to relax his or her body, how to relax different muscle groups. And then, one step at a time, you pair progressive muscle relaxation with that step. So you'd have the child seeing pictures of the dog and going through that progressive muscle relaxation. And you do that over and over again until that step ceases to elicit intense anxiety, typically when it's below an anxiety rating of 5 out of 10. And then you move to the next step, and you pair that step with progressive muscle relaxation. Okay, so that is systematic desensitization, and you move through the hierarchy, pairing each step with this relaxed state. Okay, but what actually happened, that was 1954. That makes a lot of intuitive sense, and what some careful researchers did is they asked whether it was necessary to teach that relaxation, right? So the key part of reciprocal inhibition is that there needs to be some incompatible state to inhibit that anxious state. You need to be relaxed in order to stop the anxiety state from coming up. So what these researchers did was they did treatment with individuals with phobias, and they did the treatment with or without relaxation. So they did exposure, moving through the fear hierarchy, either with pairing it with relaxation or without pairing it with relaxation. And if reciprocal inhibition is true, that we need to teach people to relax in order to inhibit that anxiety, then what should have happened is that the group that got both the exposure and the relaxation should have done better. And that is not what happened. It actually didn't seem to matter if you got relaxation or not. It wasn't hurtful to get relaxation in addition to exposure, but it did no better than just moving through the fear hierarchy alone. So what that told us was that reciprocal inhibition was not necessary, or it could not explain why exposure works. And clinically, what that also tells us is that it's not necessary to teach individuals to relax in order to do exposure therapy, in order for exposure therapy to work. So the next kind of explanation that came up for why exposure works is what was referred to as emotion processing theory. And this was Edna Foa, and you may be familiar with Edna Foa as the developer of prolonged exposure for PTSD, which is treatment that's mostly been used with adults and has actually just been tested with adolescent girls and has shown really good outcomes. So her theory of why exposure works was that anxiety reduces because during the exposure, the individual gets to accumulate new information. So she saw exposure therapy as exposure not to the feared stimulus per se, but exposure to new information. And in this context, what new means is that the information is incompatible with that fear structure, that anxious belief system. So for example, that the individual, the child or the adult, might have the belief that I won't be able to calm down if I'm around a dog. I won't be able to, if the plan after going to see the dog was to go play at a park, I won't be able to do that. I won't have a good time. I'll be too anxious. That's the belief. And doing the exposure, the child or the adult might get to see that that belief isn't true. So in this context, exposure is seen as not just getting the child or the adult around the feared stimulus, but getting them around the feared stimulus so that they can learn something new. And this has a lot of support. There's a lot of research supporting this. This theory makes some very specific predictions, some of which weren't true, some of which weren't true, and those are pretty technical that I'm not going to talk about. Needless to say, that theory's kind of been modified. And now how we think about exposure therapy is we think about it in the context of classical conditioning. So we think that exposure therapy for anxiety is analogous to fear extinction learning. And fear extinction learning comes from the classical conditioning paradigm. And I'll talk a little bit more about that and give some examples. But basically, classical conditioning is predictive learning. So you're probably familiar with the conditioned stimulus. So initially, conditioned stimulus doesn't elicit any response until the conditioned stimulus is paired with something else. And if it predicts that something else, then the conditioned stimulus might elicit a conditioned response. And again, I'll give an example of that. So that's classical conditioning. That's learning to acquire a response. Extinction learning is learning to no longer require that, no longer exhibit that response. And extinction learning is not forgetting. It's new learning. It's learning specifically to inhibit an old association. So in fear extinction learning, it's learning that the cue is not a predictor of danger or a feared outcome. So I'll give some examples of that. So this is Pavlov's example, right? So there's a ringing bell, that's our conditioned stimulus, and there's food, which is our unconditioned stimulus. And initially, these are not connected in any way, so there's no relationship between the bell and the food. But if every time you ring the bell, it is followed by food, then what happens is that the bell, or the conditioned stimulus, is now a predictor of the food. And because the conditioned stimulus is a predictor of the food, it elicits a conditioned response. So the key part here is that whether or not the bell or the conditioned stimulus elicits a conditioned response depends on whether or not it is a predictor of an unconditioned stimulus. So the association between those two stimuli is essential for eliciting the conditioned response. Okay, so if we apply that to our kind of the case example that we're using with the dog with child phobia, or a child with dog phobia, the conditioned stimulus is a dog, and we'll pretend for a second that there's no kind of innate response to a dog. And the unconditioned stimulus is being bitten, the pain, the physical injury of a bite. And initially, there's no relationship between those two. But if a child is bitten, then the dog is now a predictor of that unconditioned stimulus. So seeing a dog signals the possible occurrence of a bite or physical injury. Those two are now connected. And not just connected, but the dog is a predictor of the negative outcome. So if the dog is a predictor of the negative outcome, the dog can elicit the conditioned response, right? So again, the key point is that the dog is a predictor of the feared outcome. And that is why the dog elicits anxiety. It doesn't just randomly elicit anxiety. It's because it's a predictor of a bad outcome. Okay, so if that dog becomes a less reliable predictor of being bitten, then the anxious response will weaken, right? So the anxiety response is proportional to the association between the dog and the expected physical outcome. And as I mentioned before, avoidance is kind of the hallmark symptom of anxiety. And avoidance prevents the child or the adult from learning this naturally. So as the dog acquires the ability to elicit anxiety and the child avoids dogs, the child cannot learn that the dog is not actually a good predictor of being bitten. So the focus of exposure is to do exactly that. Your goal in exposure therapy is to get the individual to be around the feared stimulus, in this example, to be around a dog, to learn that the dog is not a good predictor of a bad outcome. You can be around a dog and everything's okay. And if you can break that association, you then break the ability of the dog to elicit anxiety. So the key part here is you're not trying to reduce anxiety specifically. You are trying to weaken how good of a predictor that dog is of a bad outcome. And if you can do that, the anxiety goes away in its own. So that is kind of our understanding of exposure therapy now. We see it as analogous to fear extinction learning within a classical conditioning paradigm. So our jobs as therapists is try to enhance this new learning, the new learning being that the dog's not a predictor of the feared outcome, that the feared stimulus is not a good predictor of the feared outcome. And we are trying to enhance how well our client can learn that. Okay, and there's two ways that we can go about implementing exposure therapy. So the traditional way of doing exposure therapy focuses just on identifying the feared objects. And you identify the feared objects and you confront them. And you kind of let everything else happen as it will. So if there are anxious beliefs, if there are anxious associations, you kind of let those take care of itself. You don't focus on any thoughts or beliefs. You just focus on identifying the feared objects and confronting them. Another way that you can do exposure therapy is to couch it as what's called a behavioral experiment. So what that means is not only do you identify what the feared objects are, but you also identify why the individual is afraid of those. So you would identify what the expected bad outcomes are. So, okay, if you're around a dog, what do you think would happen? Oh, you think that the dog would bite you. What else do you think would happen? The dog would bite you, and you'd be very anxious, and you wouldn't be able to calm down. So you kind of elicit all of those expectations, and then you couch the exposure therapy as an experiment to test all of those predictions. So couching it this way, the idea is that it's supposed to draw out that association better so that the disconfirming evidence is internalized better. So if you draw out exactly all of the prediction that the child thinks is going to happen when they are around a dog, you do the exposure, and then you revisit those expectations. Okay, did the dog bite you? Okay, it didn't bite you. Were you able to calm down? Okay, and you were able to calm down. So those things that you were expecting to happen, all those bad things you were expecting to happen when you were around a dog actually didn't happen. What do you think about that? So by drawing out those beliefs, you're supposed to be, the idea that you're kind of enhancing that extinction learning. And there is some evidence that doing that, drawing out the beliefs about why the situation is dangerous, is actually better than just doing the exposure alone. So confronting the feared objects, hands down, worked. No one argues that. But then there's actually some evidence that drawing out the beliefs works in addition to that. And I'm going to talk a little bit about some basic procedures that you would use to implement exposure therapies. The first thing that you start with is some type of a rating scale for anxiety. So you might call this an anxiety thermometer. Some people like to take it from 1 to 100, with 100 being the most anxious. Some people like to go to 1 to 10. I like to go to 1 to 10 just because it's quick and dirty. I don't know if there's a meaningful difference between, 52 and a 56. So it's like a 5 versus 6. And when you are making your rating scale or your anxiety thermometer, you also want to have anchors for it that are meaningful to the child or for the adult if you're doing it with an adult. So in this example that you see here, on the left side is kind of a word that the child uses, that the child's word for when they feel that. So when a child's at a 10, this child referred to that as being very extremely worried. And to anchor it so that both you and the child know what you're talking about, or talking about the same thing, is you come up with a situation where the child has felt that in the past. So in this example, on the right-hand side, you see anchors for the different anxiety ratings. So at the top, it's a 10 when mom drives the car when she's sick, versus a 5 is when this child loses cards. So this helps the child be able to, it helps make those rating scales a little bit more meaningful to the child. They can put it in concrete terms. So you definitely want to develop this, because this rating scale is how you track the anxiety over time. And if you don't have this, you don't have a really clear way of knowing the child's anxiety is going down. The child can't see it as well either. So you can always refer back to these numbers. It's very helpful. Like, oh, remember the first time you did this, it was an 8. And now when you do it, you're a 4. Look at that. And it's encouraging. You can see progress. So the first thing you definitely want to do is to get some type of anxiety thermometer. And then there are different ways that you can implement the exposure therapy. So like I mentioned before, that there's imaginal exposure. So this is when the child doesn't confront the situation in person, but rather imagines it. And this is helpful when the situation is not as easily simulated, such as, like a good example of this might be if a child has a lot of anxiety about flying. You can't always do in vivo exposure on an airplane, so doing imaginal exposure would be helpful in that context. Versus in vivo exposure is when you actually present the feared object in person to the child or the adult. As mentioned before, graded means you're going through kind of bite-sized portions of the fear hierarchy. So they're going through progressively more intense aspects of the fear hierarchy. And flooding is when you're going through a single or less numerous episodes of more intense and prolonged exposure. Okay, so I'm going to give some examples of how you might implement those different procedures using kind of a mixture of cases that I have worked on. So in this case that I'll use here, we'll say that the client is Billy, a 9-year-old boy, was in a car accident, a motor vehicle accident, while riding a bus on the way to school. Afterwards, he developed PTSD symptoms, which included avoidance of bus-related stimuli, such as seeing buses in real life, seeing pictures of buses, seeing buses on TV commercials or TV shows. And again, I want to point out here that so in these examples, I'm going to be doing exposure with by confronting bus-related stimuli. And as I mentioned before, you do not want to do exposure in situations where the situation is actually dangerous. You want to do it when the situation is believed to be dangerous, but not actually dangerous. So in this example, buses are not realistic danger. Understandable why this child was afraid of buses, but buses are not a realistic danger. And again, like I mentioned before, you want to do exposure when it's cue-specific, when the anxiety has some type of focus to it. So again, in this example, the anxiety was very specific in the sense that the bus, a very specific cue, was what was driving a lot of the anxiety. And we'll assume in these examples that this child has received the practice skills. So we've already done psychoeducation, we've already done relaxation, we've already done cognitive coping, and some of the affect regulation skills. So we're going to assume that Billy already has those before we jump into the exposure. Yep. Okay, so the first example, we'll look at how you might do graded imaginal exposure. So we have already done our anxiety rating. So we have our anxiety thermometer. And the next thing that you would do is you would develop a fear hierarchy. So this is, you kind of think of this as a ladder. And you want to move up the ladder and you want to start at a certain rung on the ladder. So here I'm showing steps 5 through 10, the number indicating how anxious Billy would be if he were to do that. So you do this in collaboration with the child and or the caregiver. And I'm starting at 5. As a typical rule of thumb, you don't want to start below a 5 because having the child do something that only makes them anxious to say a 3 out of 10 is trivial. And it's not eliciting a lot of anxiety. There's not a lot of anxiety there to begin with, so you wouldn't want to start there. You typically want to start around a 5. With that said, sometimes you don't want to start at a 5 and you want to start earlier. Like I mentioned earlier, you don't want exposure to be a bad experience. You want the child or the adult to have a sense of success or efficacy. So if your clinical judgment and your discussion with the child and or the caregiver suggests that the child can't start at a 5, that it won't be a good experience to start at a 5, then you might want to back up and pick a situation that's a 4 or a 3. So you want to be mindful that that the child has a chance of succeeding with it, basically. So in this example, we'll assume that Billy could start at a 5, and you might, or in this situation, it might have been seen a bus on the computer. So not seeing the bus in person, just seeing pictures of the bus on the computer. And something that made Billy a little bit more anxious was seeing a moving bus on either a TV show or on a movie, just seeing the bus moving. What made Billy more anxious was actually seeing the bus in person. So the hierarchy, or the step that we put in the hierarchy, was seeing the bus stop near his house, and stop by his house is kind of down the road from his house. So and the next step after that, not just seeing the bus in person, stopping by his house, but the next step after that was standing up close to the bus, and then stepping onto the bus, and then actually riding the bus to school. So again, with graded exposure, what you're doing is you're tackling it in kind of bite-sized portions, and you're moving to the next step when you've had success at the current step. So we moved to step 6 when Billy feels comfortable, step 5. We moved to step 7 when Billy feels comfortable, step 6, and so on. Okay, you may or may not start with the relaxation exercise. Like I mentioned earlier, research shows that you do not need to do relaxation in order for exposure to work. But, as I also mentioned, relaxation doesn't hurt the exposure. So if based on clinical judgment or the child's ability or willingness to start the exposure, you might want to try starting the exposure by putting Billy in a relaxed state, or going through the diaphragmatic breathing, or going through the progressive muscle relaxation. So not necessary, but it can be helpful sometimes to get the child to engage in the process. And also, you may or may not incorporate some type of contingency management into this. You're less likely to do this with adults, but if you're doing it with children, it's often helpful to have some type of reward after they either try each step or complete each step. And depending on the child's age, some ways that we've done this in the past was to go to the dollar store with their parent, and they might get 5 to 10 toys, put them in a bag, and every time that they finish a step, they got to reach in the bag and pull out a toy. So the idea is that there's some encouragement for completing these steps because it's challenging. You know, it's emotional work for the child, and you want to reward them for that effort at each step. So, and again, that's not necessary, but that can be helpful sometimes when working with children. So if you're doing imaginal exposure, what you would do as a therapist separately is you would write a script of each step. So, for example, one of our steps is seeing pictures on a computer. So you would write a 30-second script that describes Billy doing that in the present tense. And when you're writing these scripts, you want to use as much sensory detail as possible. So what can you see? What can you hear? What can you sense? What physical reactions are you having? What do you notice your heart doing? Do you notice any sweating? So in these 30-second scripts, you try to describe the situation that they're imagining confronting in as much detail as possible, and what their reaction to it is. So loading it up with as much sensory detail as possible. So you'd have a 30-second script of that ready. You'd have, you start with Billy providing anxiety rating. So he might be at a 5 before you start. Then you ask Billy to close his eyes. While his eyes are closed, you ask him to imagine the situation you're about to read is happening right now. And then you read the situation. So 30-second script, and you get another anxiety rating. He might still be at a 5. And you do this over and over until that anxiety drops. And the typical rule of thumb is that you want the anxiety to drop in half before you get to the next step. So if Billy starts at a 5, you want to get him to a 3 or lower. And you just keep going over that same script, getting the anxiety rating, doing the script, getting another anxiety rating, talking about what it was like, what did you notice, what physical sensations did you notice, and doing it again until you get that anxiety rating to drop by half. Okay, so in vivo exposure, we're going to use the same steps. So if we're doing in vivo exposure with Billy, we would again start with our anxiety thermometer. We would start with our fear hierarchy. We would develop that. And again, we may or may not start each step with the relaxation exercise, and we may or may not incorporate contingency management, based on clinical judgment, based on the child's needs and ability to engage in the exposure. If we're doing in vivo exposure using these same steps, what you might do is if you had Billy in your office, you could actually, do a Google image search for school bus, have Billy sit next to you, and look through each of the pictures that pops up. And what can happen when you're doing exposure is that the child or the adult can kind of covertly avoid. So they're there, Billy could be sitting there next to you, but he's either not looking at the pictures or he's looking at the pictures, but he's kind of mentally checked out somewhere else. So to make sure that Billy is engaged in this, you might ask him questions. So if there's a bunch of school pictures that pop up, you might have him notice a particular one. You might have him pick one out. Say, which one of those stands out to you the most? Oh, tell me about that one, right? So you're having Billy engage in the process, so he can't covertly avoid. And when you're doing in vivo exposure, you want it to last at least 15 minutes. There's lots of different rules of thumb as to how long it should last, but I've never heard anyone argue it should last less than 15 minutes. So you want to try to keep it around 15 minutes of exposure. Every few minutes while you're doing this, you want to check in on anxiety, or on Billy's anxiety rating. So if you started out at a 5 before you started, and you're looking at some pictures, it might spike, it might go up to a 6 or a 7, and you keep going, keep looking at them, keep talking to him about it, keeping him engaged in looking at the pictures, and keep getting those anxiety ratings every few minutes. And just like with imaginal exposure, the typical rule of thumb is you would move to the next step when the anxiety has dropped in half. So you might spend a couple times looking at the buses on the computer before Billy goes to the next step. And you make it collaborative, so you don't just throw him into the next step until he also agrees that he's ready. And one cue for you that he's ready is that the anxiety is reliably dropped in half. So then you might move to the next step, where Billy sees a bus in a TV show. So in collaboration with Billy and with his caregiver, you might get a DVD of a TV show that includes a bus riding in it, or where children are on a bus. And you would watch that with Billy. So again, you'd start with anxiety rating, get it every few minutes during it, and you would repeat that until Billy's anxiety rating reliably drops in half, and he agrees to go to the next step. So the next step might be seeing a bus stop by his house, and you may or may not be able to do this with Billy. If you cannot do these, then you really want to plan and prepare with the caregivers to do it with the child. Like I mentioned before, therapist-directed exposure tends to work better than self-directed exposure. And you can't always do the exposure with the child or the adult. So if you're going to have them do it on their own, you really need to prepare with them how to do it, how long to do it, and have all the parameters set up ahead of time to make it as likely as possible for it to be successful. And you want to limit the possibility for avoidance. So if the plan was, in this example, to walk to about a block away from where the bus stop is, as the child's walking there with the parent and you're not there, the child might have the idea, what if we just stop at 2 blocks away? And without preparing the parent may agree to that, and that's reinforcing avoidance behavior, and that's what you don't want to do with exposure therapy. So you want to prepare the caregiver for that ahead of time and make it very clear what's supposed to be happening and what the expectation, how to deal with resistance, et cetera, et cetera. And you also teach the parent to get the anxiety ratings beforehand every few minutes during it. So the next step, again, assuming that this is happening with the caregiver and you planned it with the caregiver, you'd have Billy stand up close to the bus. The next step would be stepping onto the bus. And then the last step would be riding the bus all the way to school. And again, the key point is you don't go to the next step until, as a general rule of thumb, the anxiety drops in half at the current step, and Billy agrees to go to the next one. So if he doesn't agree to go to the next one, or his anxiety is not dropped in half, you do it again. You might go back, once a week or every day until that does happen. But you're not moving backwards. You're staying at the current step until the anxiety drops in half, or he's willing to go to the next one, and you keep moving through it. And as mentioned before, there's some evidence that couching exposure as a behavioral experiment is actually more helpful. Again, exposure therapy alone, hands down, efficacious. Might be evidence that it works even better if you couch it as a behavioral experiment. So if it's developmentally appropriate when you're working with a child, you might ask the child what some of the expected outcomes are that are fearful. So you might look at stimulus expectations. So what will happen if you see that bus on the computer screen? Affective expectations. So what are some expectations about how Billy will feel, how Billy will respond affectively? So how will you feel if you see that bus on the computer screen? How long will you feel that? Where will you feel that in your body? So drawing out all those expectations or coping expectations. If you did see that and you did have that feeling come up, or that your heart did start to race like that, would you be able to cope with that? Do you think that you'd be able to tolerate that? What do you think would happen if you felt that? So drawing out some of those expectations prior to doing the exposure step, then doing the exposure step, and then checking back in on those expectations. So as an example, if we did the graded exposure with step 5, seeing the bus on the computer, we might ask Billy, what will happen if you look at the pictures? And he might say, I'll get scared. You might say, how scared? He'll say, 10 out of 10. And then you say, how long would you feel like that? And Billy might say, I'm going to feel like that the rest of the day. So you hold on to those expectations, and you do the Google image search, and you scroll through the pictures, last 15 minutes. Afterwards, you check in, and you say, did you get scared up to 10? And Billy might say, actually, I only got up to an 8. Okay, so you thought you were going to get up to 10, but you actually didn't. It was only an 8. Okay. Did you stay at an 8 the whole time? No. I actually, now I'm at a 4. So you're trying to help make it as explicit as possible that those feared expectations didn't happen. And remember, that's kind of the mechanism of exposure therapy, that you're disconfirming these feared expectations. So if you can draw them out, if it's developmentally appropriate to be able to do that, you want to try to do that. And the last thing that I will mention is this idea of safety behaviors. So safety behavior is something that can interfere with exposure therapy, and a safety behavior is something that is either believed to or actually does reduce the likelihood of the feared outcome. So some children might carry around a special toy that they believe helps protect them. Or they might want to have a parent or a caregiver around to help them in case something bad should happen. With adults, something that safety behaviors that sometimes happen is carrying around a bottle of Xanax, right? So the adult thinks, well, I may not have a panic attack, but if I do, I've got my Xanax with me. And then the problem with safety behaviors is that the lack of the outcome, of the feared outcome, gets attributed to the safety behavior and not that the stimulus was actually safe. I'll give another example of that later. But a cartoon that I like to use with actually both with children and adults is this from The Simpsons. So I'll read this through. So Homer comes out of the house, and he's all proud, and he says, there's not a bear in sight. The bear patrol is working like a charm. Lisa, a very bright young child, says, that's specious reasoning, Dad. Homer, who does not know what specious means, says, thanks. Lisa says, by our logic, I could claim that this rock keeps tigers away. Homer asks, how does it work? Lisa says, it doesn't. It's just a stupid rock. And Homer says, uh-huh. Lisa says, but you don't see any tigers around, do you? Homer says, Lisa, I want to buy a rock. And this is just a really good example of safety behaviors. So initially, Homer thinks that his bear patrol is keeping bears away, when in fact, there are no bears that are going to come around and has nothing to do with him being on the bear patrol. Similarly, there's no tigers around. Lisa could say it's because of the rock, but it's really not, right? So the idea with safety behaviors is that the individual does something they believe prevents the outcome from happening. And by doing that behavior, they can't learn that the situation itself was safe. They think it's only safe if Dad's around. They think it's only safe if they have their special toy. So that is how it can interfere with the exposure therapy. So you want to be careful if there are any safe behaviors like that going on. Sometimes there's good clinical reason for judicious use of safe behaviors. So while there is some evidence that engaging in a safe behavior can make exposure therapy work less well, there's also evidence that using safety behaviors early on in therapy can be a good way to get people to engage in therapy and get moving through the hierarchy so you can get to the more difficult steps. And you can incorporate that into the fear hierarchy. So you can think of it as a graduated step. You might look at the pictures of the bus with Dad in the room, and then the next step might be doing it with Dad not in the room. So it is okay sometimes to allow safe behaviors, like I mentioned, when first starting exposure to get them engaged in it. When it's reasonable, for example, if the feared situation is going somewhere that the child would always go with the parent, then it is okay to have that there because the inverse situation, being there without the adult, would never happen anyway. So you don't need to get the child less anxious in that situation because it would never happen. And if it's better than nothing, it's better than nothing. So if the child is only willing to try something with their special toy around or with Dad in the room, that is better than nothing at all. So just to get the child started, you might even try starting with that. Basically what I'm saying is don't see safe behavior as a deal breaker. It is, the evidence would suggest it's still better than not doing exposure at all, even if they use a safe behavior. But you want to be careful with over-reliance on them. So that is all that I have, and I guess I will turn it over to some questions. I guess we've got a couple minutes left if anyone has any questions.
Thanks, Josh. Yeah, so if you have a question to ask Josh, you can use the chat feature, the little bubble on the right side of your screen. I think for the November webinar, we're still trying to finalize a speaker, but it's going to be about therapeutic foster homes and kind of what that model is about and how that program works. So I know a lot of us have clients who are in those settings. But Josh, I just had kind of a real quick question. I know we're at the top of the hour, but what's sort of when you're working with adults versus children, kind of what are the biggest differences when you're doing exposure therapy for them? Can you talk a little bit about that just briefly? Or
yeah. So in terms of like being developmentally appropriate, I tend to be more encouraging with children in the sense of saying, you can do this, kind of building up their self-efficacy in regards to tackling something that's very scary. Whereas opposed to with adults, when I'm doing some type of exposure therapy, I'm focusing less on being encouraging or building up self-efficacy and a little bit more focused in drawing out some of their expectations. So if they're hesitant, why are they hesitant? So in my experience, I think it's easier to draw out some of those feared expectations in couching exposure therapy as a behavioral experiment with adults than I've had with children. Sometimes children aren't as good at identifying exactly what it is that's scary about the situation. So in those situations, you might focus on just identifying the situation and being really encouraging that they can conquer it, as opposed to just confirming expectations. So it looks like we got another
Oh, yes.
question.
Question regarding whether or not we'll get a copy of the slides. Yes, I can send an email out to everyone with a copy of this presentation. And that's also a good way, too. If you have follow-up questions for Josh, I think you all have my email. I can forward those on to him.
Yeah.
Last opportunity to ask questions. I realize we're kind of at the top of the hour here. So I want to thank Josh again for taking the time and introducing this topic. So any last questions? All right.
Okay.
Well,
thanks, everyone.
Thank you all so much, and be looking for future emails.